I'll be discussing the advances in endoscopic management of gastric cancer. So this is the overview of my talk. I'll be discussing in the role in diagnosis, the role in endoscopic resection, in local staging, and the advances in palliation. So first, I'll be discussing the role in diagnosis. So if you actually look at the history of endoscopic evaluation, stomach was a space that was, that could not be evaluated in the early 1800s. Still, Adolf Small was able to pass a rigid gastroscope into the stomach and visualize. So he published his seminal papers on visualization of the stomach. Subsequently, rigid and semi-flexible gastroscopes came in, and they gave us insight into what goes on in the stomach. And Borman, based on these endoscopes, gave his classification of gastric cancer in 1926. And this is something that has been the standard of care till maybe 30 years back. Basil Hurstowitz in Michigan in 1957 developed the flexible gastroscope, and this brought a paradigm shift in the practice of endoscopy. So we shifted to flexible endoscopes since then. And because endoscopy became easily accessible with increasing rates of gastric cancer, Japan started screening for gastric cancer in the year 1983. We found out about H. pylori soon, and in 1994, WHO classified H. pylori as a class 1 carcinogen, and it gave further impetus to the science of endoscopy. So more people were interested in endoscopic evaluation for gastric cancer. Then in the early 2000s came, dye-based chromoendoscopy, because the scopes were not great. So it was not very good at visualizing early gastric cancers. And to visualize early gastric cancers, they started using dyes like indigo carmine and methylene blue. And then slowly we moved to high definition endoscopy with magnification and image enhancement. So now we are using these high definition scopes for all our endoscopies, and hence the detection of early gastric cancer has become easier. Now, endoscopy is the primary modality used for screening in gastric cancer. So there are programs that are available in Japan and in South Korea who recommend screening starting age 40 and age 50. And they saw that with screening, there was a 38 to 63% reduction in gastric cancer mortality. But if you look at the West, the American Gastroenterological Association recommends only surveillance in gastric intestinal metaplasia. So there's no screening. And again, the British Society recommends screening with multiple risk factors, especially the presence of pernicious anemia. So if you look at Indian scenario for screening, so data from Globocan would say that there are close to 65,000 new gastric cancer cases in 2020 and almost more than 50,000 deaths. But the age standardized rates are low due to a large population, but it is expected to increase by more than 62% by the year 2040. The highest rates, I think already Dr. Prasad has discussed, is in Mizoram, and we do not have a formal screening program. So what is the outcome of this? So this is a series of gastric cancer from TMH, which we are in the process of publishing. So our mean age is around 50 years, 70% are male. But if you actually see, more than almost half of the population present with stage 4 disease. So almost half are metastatic at presentation. And almost 37% had gastric outlet obstruction, and a good 3/4 are nutritionally suboptimal. So there is a lot of debate on the role of endoscopy for screening. Now, as of now, it is not a recommendation, but maybe as time passes, there might be a recommendation for the same in areas where there's a high incidence of gastric cancer. So white light is the primary endoscopic modality that is used across by most practitioners. So, but the problem with white light is that it is associated with a low sensitivity for detection of precursor lesions like gastric intestinal metaplasia, even dysplastic lesions, and early gastric cancer. So detection early will reduce mortality, and up to 9.4% of early gastric cancers are missed on a routine upper GI examination with white light. And which is why early practitioners started doing dye-based chromoendoscopy. You can see here, it is not clearly delineated, but with the dye spray with methylene blue, it becomes clearly delineated, and it increased sensitivity to 90% and specificity up to 80%. Now, although there was an increased diagnostic yield, but there were issues with respect to standardizing the dye that was used, and it was also reasonably cumbersome to perform. Of course, the standard terminologies also changed over the years. So now initially, like discussed, Bowman classification was the standard of care. It was similar to the Japanese classification, which has already been discussed. But the Paris classification came in 2002, and this was largely described for early lesions. And it changed the paradigm for reporting in early gastric cancer and helped decide if endoscopic resection is feasible or not. So there were three subclasses, 0, 1, 0, 2, and 0, 3. Now, this was the 0 was based on Borman having 1, 2, 3, 4, but they said early would be Borman 0. And based on that, they subclassified into 4 types. And 0, 0, 1, 0, 2A, and 0, 2B are largely considered endoscopically resectable. There are some difficulties in performing endoscopic resection for 02C, and 03 is ulcerated lesions where endoscopy is not usually performed. So typically it helped us to decide if endoscopic resection is possible or not. Then of course came the era of the virtual chroma-endoscopy. I think Dr. Prasad already mentioned about narrowband imaging. So it helped to change, just like a dye filter with a touch of a button. So it was able to restrict the light to wavelengths of 400. For detection of precursor lesions also, it had a reasonably high yield. Sensitivity improved to 69%, specificity as high as 90%. And it increased the detection of focal gastric lesions up to 40%. Now, for the newer endoscopes, there's again a further enhancement. There's almost a 150 times optical zoom without a depreciation in the image quality. And a large number of endoscopists will use a transparent cap for better visualization of the mucosa. So based on this narrowband imaging, this was a modified VS classification that was described for early gastric cancer in 2009 by Yao. And it was based on 2 factors, the microsurface pattern and the microvascular pattern. So you can see the vascular pattern and the surface pattern. And this was modified by addition of a demarcation line by Yamada in 2014. It increased the yield of diagnosis with sensitivity of 95%, specificity of 96%. And it also helped to delineate the lesions better, especially in those situations where chromo with a routine dye like methylene blue or indigo carmine was not working too well. So based on this, there was an algorithm that was given for diagnosis of gastric cancer, and this was called the MESDA-G algorithm. So if there was any lesion that was suspicious, you do an NBI and you see a demarcation line and you see an irregular microsurface or microvascular pattern, you can consider dissection. So the accuracy was high, up to 95% with a high negative predictive value of 97%. Again, now there's further improvement. There's role of artificial intelligence that has come in the last 4 years. So there is increased sensitivity with the use of convoluted neural networks that have come in. A recent meta-analysis published in 2021 showed that AI is actually better than routine endoscopists that perform an endoscopy. But a subgroup showed better accuracy in programs who are trained with at least 10,000 images at the baseline. But again, the challenges are the cost and the logistics, and further validation is needed. Now coming next to the role in endoscopic resection, now moving from NBI to the role in endoscopic resection, because NBI actually precedes resection. So the rationale would be like once you diagnose early gastric cancer, it is usually confined to the mucosa or submucosa. And the 5-year survival is very high, 99-96% for T1A and T1B. And lymph node metastases are usually low when the cancer is restricted to the mucosa. So with appropriate risk stratification based on NBI and other modalities, we can avoid a major surgery. And endoscopic resection not just can avoid surgery, but sometimes may help in accurate pathological staging prior to a major surgery. So there are certain indications for an endoscopic resection. Now, there are 4 criteria that we look at. Usually the depth of invasion, if there's the presence of an ulcer in the lesion or not, and what is the histology, if it's a differentiated cancer, well-differentiated cancer, or an undifferentiated cancer. Now, an absolute indication for doing an endoscopic mucosal resection or an endoscopic submucosal resection would be any lesion less than 2 centimeters, differentiated without an ulcer, restricted to the mucosa. Again, ESD can be done for larger lesions also, and even in undifferentiated lesions. But even in the presence of an ulcer, for lesions less than 3 centimeters. But again, for lesions more than 3 centimeter, this endoscopic resection, and especially in those with submucosal involvement, there is still a debate on whether endoscopic resection should be done or not. So there is a question of where to use EMR, where to use ESD, and where to send the patients for surgery. So EMR is simple. You see a polyp or a lesion, you inject the base of the lesion, you lift it, and you apply a snare and you cut it, and you retrieve it with the polyp. But the problem here is that the margin may not always be clear, and sometimes you might get an incomplete resection. You might not be able to resect the lesion en bloc. On the other hand, an endoscopic submucosal dissection, what happens is that we're able to do an appropriate marking of the lesion. We're able to inject and cut the margin of the lesion, dissect the base, and resect the lesion en bloc. So if you actually compare EMR versus ESD, EMR is usually avoided for lesions more than 2 centimeters. Again, presence of ulceration EMR cannot be done. So there is a higher rate of en bloc resection, complete resection with ESD, but of course there is more time taken and higher risk of perforation. So how will you choose whether to do an EMR or an ESD is largely dependent on the patient's condition, the characteristics of the lesion. So like I said, if there's an ulceration or if the size is big, you won't do an EMR. A therapeutic environment at the treating institution. So there might be protocols at the institution. And lastly, of course, ESD requires a lot of expertise on the endoscopist part. It's a time-consuming process, high risk of complication. So it requires significant amount of training before performing an ESD. So cure can also be achieved endoscopically if there are certain criteria that are fulfilled. So that is where the role of pathological staging after endoscopic resection comes. Now, if there's a differentiated cancer or an undifferentiated cancer restricted to the mucosa, and if there's no ulceration, and if the horizontal margin are negative, the vertical margin is negative, if the lymphatic emboli are not seen and the vascular emboli are not seen, it is considered that there is a cure that has been achieved. Again, if the lesion is resected en bloc, it is predominantly differentiated and less than 3 centimeters, despite submucosal invasion of less than 500 micrometer. You can presume if there is the horizontal and the vertical margins are negative and lymphatic emboli are not present, vascular emboli not present, that cure has been achieved after endoscopic resection. Now, if these criteria are not fulfilled, then technically the patient has to go for surgery. Now, coming next to local staging. Now, this is where the role of EUS actually comes in. So EUS is primarily used for T staging, helps differentiate between cancers which are operable versus those who also that need neoadjuvant therapy. Now, there was discussion on whether differentiation between T1, T2 can be done. It can be done, but the sensitivity is lower. So largely used in our practice to differentiate between T1, T2, and T3, T4 lesions. The sensitivity is of around 86%, specificity of 91%. And the decision making is switched in up to 1/3 cases in a previous study. And almost 85% in their series, the decision changed from surgery to palliation. Again, nodal staging can also be done based on morphological criteria. If the node is round, hypoechoic with a sharply demarcated margin and more than 10 millimeter size, then you can presume that the node is malignant. But again, it has a poor sensitivity with all criteria seen only 25%. So you can see this is a ulcerated lesion in the stomach, and this is the EOS image. This is a hypoechoic lesion, and it is involving up to the muscularis propria. So it's a lesion. So this is usually a T2 gastric cancer. Again, of EOS in the therapeutic context or doing some intervention of some sort. So like we discussed, nodes are usually presumed to be malignant when you by the appearance, but sampling of lymph nodes may actually help, may change staging, especially if there are mediastinal lymph nodes in patients with gastric cancer. Sampling, especially in a country where there's a very high prevalence of tuberculosis, is justified. But overall rate of sampling, despite finding nodes, is reasonably low, less than 10%. Again, in patients with extrahepatic biliary obstruction with an accessible papilla, ERCP is considered the standard of care. But some patients with gastric cancer may present with obstructive jaundice. And in those situations, endoscopy endoscopically, EOS guided biliary drainage can be done, which is a potential option over PTBD in patients with an altered anatomy and in patients with inaccessible papilla. Now, what is the advantage here is that it helps to optimize resource utilization, because the patient can be converted on table from an ERCP to an USBD right away. And of course, it has a high rate of technical and clinical success. I'll come to EOSDJ in the next section. So moving on from local staging to the advances in palliation. So palliation, again, nutrition is the key to improve survival and is associated with better performance status and the quality of life. Now, again, malnutrition may be seen in up to 75% patients with gastric cancer, and the major contributor remains gastric outlet obstruction. Now, there are potential options for treatment. These include, now this again, I'm talking about gastric outlet obstruction. The proximal cancers are more difficult to treat, usually require a tube, which can be placed endoscopically or with the help of interventional radiologists. But in distal cancers, typically there are three options. You're looking at either doing a surgical gastrojejunostomy, placing an enteral stent across the tumor, or doing an EOS guided gastrojejunostomy. Now, the issues with the surgical gastrojejunostomy, of course, an open or a laparoscopic surgery. The procedures require a longer recovery and a longer time of admission and a higher resource utilization in high volume settings. Now, of course, enteral stents have been in use in practice for over 30 years now. They're easy to perform. It's a short procedure with a short recovery. Usually, we do not even admit our patients for enteral stents. And there's a faster time to oral intake. Now, we usually do an X-ray in the evening and the patient will start the oral intake. It needs a larger channel endoscope to perform. So most endoscopists, most gastroenterologists during the clinical training will perform these procedures. The SEMs are made of nickel and titanium alloy called nitinol. So they have the properties of high tensile strength while also having flexibility with the ability to pass across angulated strictures. So a recent systematic review showed a high technical success of 97% with a clinical success of 85%. But there are some predictors of clinical failure. These include the presence of peritoneal carcinomatosis and a poor performance status. So now EOS guided gastrojejunostomy has come in. This has come in 2012 when Binmuller first described it in a porcine model. Now, this is again a short procedure, fast recovery, high technical and clinical success. Now, we use something called the lumen opposing metal stents, which have the wide anti-migratory flanges to establish the anastomosis. And there are multiple different techniques for that have been described, wherein with the EOS, we can directly puncture with the stent, or we can put a wire from the stomach into the jejunum, and over that we can route it. And sometimes you can fix the loop of the jejunum with something called a double balloon, which has been used for enteroscopy. You fix the loop of the jejunum because it's mobile and then take a puncture. So a recent meta-analysis showed that the technical success is high, almost 92%, with a high clinical success. And initial clinical rate of clinical success is higher than a duodenal stent because it's not passing across a tumor. But the complications may be seen, especially for novice endoscopists. The complication rate may be high, with perforation, peritonitis, stent maladeployment, migration, and bleeding known. But the major advantage is that, again, you're able to resume oral intake quickly on the day of the procedure, and the need for hospitalization is usually just for 1 day. So which modality to choose? Now you have three modalities. So there is a systematic review, again published in Landing Index in 2021, which showed that EOSGE was better than enteral stents with rate of, when you look at clinical success, obstruction, stent obstruction, and tumor endo. Again, as compared to surgical gastrojejunostomy, the rate of clinical and technical success was similar, but the number of days of admission were lower for EOSGE. Again, in another meta-analysis, it was shown that the gastrojejunostomy had a faster resumption of oral intake, shorter hospital stay, earlier resumption of chemotherapy with lower overall costs as compared to surgical gastrojejunostomy. But this was in the West. And lastly, this is a meta-analysis published recently in 2022. Again, EOSGE was shown to have a similar technical and clinical success as compared to a surgical gastrojejunostomy with a lower rate of adverse events. Now, so what do the guidelines say? So again, if you look at the AGA guidelines that were published last year, They would say that if the life expectancy is more than 2 months with a good functional status, it is best to do a gastrojejunostomy. You can do surgical or endoscopic. And for patients who are not candidates for a GJ, you can consider placement of an enteral stent. Now, enteral stent should not be used with multiple levels of obstruction. In peritoneal disease, you can actually think whether the patient will benefit or not. And again, in patients with severely impaired gastric motility, you might not want to place an enteral stent. And depending on the experience of the endoscopist, EUS GJ is an acceptable alternative to surgical gastrojejunostomy and enteral stent placement. But the issues in India, again, multidisciplinary teams are not available in all institutes. So again, decision may be largely driven by where the patient goes. The cost of the interventions, especially the endoscopic interventions, remain high. And again, the skill of the endoscopist remain variable. So these are technical issues that remain. So my take-home messages are image-enhanced endoscopy is highly effective in diagnosing early gastric cancer. The criteria for endoscopic resection using EMR and ESD are defined based on the risk of recurrence. Differentiation, depth of invasion, the presence of lymphatic and vascular emboli will not just decide resectability, but also help to define if cure has been achieved endoscopically. EUS has a role in certain situations in diagnosis and in therapy. And palliation can be done endoscopically using enteral stents and EUS gastrojejunostomy. Thank you.